you the perfect interpretation fitting to a perfect morphologic finding, because histopathologically this is a clear melanoma, so it's not an ambiguous lesion. It's easy to interpret. In real life, you might not need molecular biology at all. In this study, Jeremy and co-workers looked at the sensitivity and specificity of fish in melanoma diagnosis. And from this study, I just show you the problems that are associated with the methods. First is that it's not a yes-no answer. It's an algorithm you have to go through where certain criteria have to be fulfilled. And the next problem is that not only there is the algorithm that you need to go through, but also you have cut-off levels. So each lab has to define, in the end, by their own standards, how many or how high the proportion of cells that have to fulfill the special criteria has to be. And therefore, it's not so difficult to compare results and also to reproduce results. And if you think about establishing a method in your lab, you have to be aware of this. This review article, Nevus versus melanoma, to fish or not to fish, gives a good overview and also shows the problem. You see in the first, actually in the second column, the number of melanomas that were assessed in the different studies and the number of nevi. And you see here in the last two columns the overall sensitivity and specificity. And as you can see, the sensitivity ranges from 78 to 100%. 100% usually in studies that use very low numbers of melanoma, like 8 or 10 cases. The specificity is high, between 94 and 100%. But what does it mean? In cases where you have 78% sensitivity, it means that you miss 22% of melanomas that have been diagnosed as melanomas by histopathology already. So these are not lesions where they come to the lab because the histopathologist didn't know. These are lesions where it was clear that there were melanomas anyhow. So not too sensitive, unfortunately. Yeah, that's the problem. Only unequivocal cases were included without biologic information. So what is happening now is that you compare morphology with molecular findings, but you do not compare molecular findings with biology. This is another study done by Katrin Kerl, and what they did, they tried to find an approach where they can improve the fish sensitivity, and they took 163 lesions that were diagnosed as melanomas, so there was no question about the diagnosis here. And then they looked at the available algorithms that are around. This is the Jeremy algorithm and the one by Abbott. It's a commercially available algorithm. And they looked if when they combine these two methods, if they can increase the sensitivity of fish. And this is shown in the table. So the fish-negative melanomas that have been diagnosed as melanomas by histopathology were 30% with the Abbott algorithm, 25% with the Jeremy algorithm, and you could decrease the number of missed melanomas, if you want to say so, the percentage to 17% if you combine these methods. And what they did then, and this is an interesting approach, they said, well, let's look if the fish-negative cases can be filtered out by another method, and that's the method we introduced first, by CGH. And if these cases maybe show alterations, we just don't pick them up with the probes that we are using. And in fact, that was the case. So they had 12 negative fish cases, and they found that 8 of these 12 cases showed alterations when they used CGH, but unfortunately in other chromosomes. So chromosome 1, chromosome 8, chromosome 9, whereas the probes, as I said before, of fish are located to chromosome 6 and 11. That's a problem. How to overcome this problem and what does it mean? Well, it means that to really improve the diagnosis, there are studies needed that correlate molecular findings with biology and not correlate molecular findings with morphology, because it will just not improve your diagnostic accuracy. This group looked at 113 cases with of ambiguous melanocytic lesions. So where it was difficult by morphology to decide whether it's benign or malignant. And they had two groups, patients without a recurrence and patients where there was a recurrence with metastasis. And the method was that the histopathologists were blinded, and they had to say, I favor benign or I favor melanoma. And then they did a FISH assay on the cases. And this is the study result. They found that histopathology has a sensitivity in these difficult lesions of 95%. So they miss 5% of biologically malignant cases, and a specificity of 52%, which is not too impressive, but okay, it's not the important part here. But FISH only has a sensitivity of 35%. So you miss the majority of biologically malignant lesions. And this is the table that is shown in the publication, and I just zoom now into the result here again. So A plus means the lesions were assessed as malignant by the pathologist. Minus means the FISH result was negative. And here you see the metastasis, so lymph node metastasis, but also visceral metastasis. This was another very good study by, also involved Kutzner, where they tried to classify ambiguous melanocytic lesions with FISH, and they correlated it with the long-term follow-up. And just to make a long story short, what they found is that when they compared the FISH results with the clinical outcome, they reached a sensitivity of 60% and a specificity of 50% of the method. And they say, as a conclusion, that the FISH technique with its present composition, and that can be read here, does not achieve a clinically useful sensitivity and specificity. So it does not really help you if you're not sure what it is. One attempt to overcome this is to introduce new probes. So to have probes that target other chromosomes like chromosome 9 and 8. And here is one study that is doing this. And here you see the histopathology of the lesions. They are going to, or they investigated here. And again, for the dermatopathologists, you will not need any additional method here. This is a melanoma as clear as it can get. It's like a blink diagnosis. Well, of course, the problem of is it benign or malignant is not new. It's not only now that we diagnose lesions very early. There have always been problems, and this slide you have seen before. It's the first publication of Sophie Spitz of Spitz-Nevi, and she was a pathologist. She looked at the slides and she said, that looks horrible, it must be a melanoma. If a clinician would have first seen these cases, he would have said, well, looks symmetric, circumscribed, benign, it can't be so bad. But that's one of the problems with Spitz-Nevi. And the question of Spitz-Nevi versus melanoma, we heard before from the two speakers, is really difficult to resolve. And here molecular biology would be something that hopefully could help us. Again, Bastian tried by GCH to resolve the problem. He looked at 17 cases of Spitz-Nevi, and what he found was that 13 nevi had no alterations, 1 nevus had gains involving chromosome 7, 3 lesions had gains involving chromosome 11, which means it doesn't mean anything. You cannot use it. Another interesting study was done on atypical spitzoid melanocytic tumors, and was done by the next speaker, Daniela Massi. They looked at 38 cases of spitzoid lesions, which were evaluated by pathologists and grouped into atypical Spitz-Nevi, typical spitzoid tumor, spitzoid melanoma, and in some cases they could not reach any consensus. They had a follow-up, so it was a retrospective analysis of between 8 months and 13 years, and they looked at the biologic behavior.